Hey everybody, Karen Anderson here, jumping on a few minutes early for a really special live with Aortic. It's because our guest speaker just got buzzed on one of those fancy Dr. Buzzer machines, so he's going to have to go. But I didn't want you to miss this information, as brief as it's going to be. We will have Adam back to get into greater detail about this. But Adam Ahmed started off with us as a med student. You're now a resident in University of Pittsburgh. We will get into all that later because you have to go. Talk to us a little bit about the traditional clinicians that we're going to see as part of the aortic team that we should be part of.
Absolutely. So in two broad categories, you have your clinicians and your medical specialists, and then you have your surgical specialists. So the way I kind of like to think about it is clinicians, those are going to be your cardiologists, those are going to be your geneticists, those are going to be your primary care physicians. These are the doctors that really spend the most time with you. They spend the most time in clinic with you, reviewing your imaging, tracking you. Your cardiologist is going to be responsible for scheduling your interval CT scans and coordinating it with your primary care doctor, coordinating all your different medications. So these are the doctors that, for lack of a better word, aren't cutting into you. These are the ones that are really helping manage you clinically. And they work in a multidisciplinary way, meaning multiple disciplines. They work with people from other specialties in order to kind of optimize you and figure out what's the best plan. If there is a right time to undergo surgery, and if so, when it is. Then we can start to think more about our surgical specialists. These are going to be obviously your vascular and cardiac surgeons. These might be your interventional cardiologists. These might be your interventional radiologists. So now, obviously, when we think of radiology, we always think of imaging and interpreting the different kinds of scans and things that we undergo. But now there's a whole nother exciting field called interventional radiology, where they're able to do a lot of minimally invasive surgeries and procedures where they can actually control sites of bleeding, deploy stents, and do things using fluoroscopy, which is kind of what we've been using for a long time in vascular surgery and in interventional cardiology. So it's a big team. There's a lot of moving parts, but I think this might be one of the rare examples where there's never too many chefs in the kitchen. Everyone offers a different perspective. Everyone offers a different understanding of both time-tested strategies for treatment, but also new and emerging technology. So these are kind of, the different people at hand.
And I would think if you know that you have a connective tissue disorder like Marfan's, you also want to make sure you have a facility that has skin doctor, orthopedic doctor. I don't remember
Absolutely.
which ologist for your eyes is optometrist or ophthalmology. Thank you. I know it was. I just should just go with this, and that's because a lot of those areas are directly impacted from that connective tissue disorder as well, right? So
absolutely.
Well-rounded.
So if you have connective tissue disorders, you're going to have to follow up. Not just with the cardiologist, also some kind of connective tissue specialist or geneticist. You're going to want to follow up with an ophthalmologist. You might want to follow up with orthopedic surgery, and sometimes there are people who specialize in terms of like family health clinics, and people who specialize in genetic disorders that can kind of help with family planning and things of that nature. So whenever you have a connective tissue disorder, you inherit a big list of doctors that really all help take care of something different.
I see you looking at your little buzzers. I mean, you got to go, like they rolling in right now.
I got 2 minutes.
All right, so 2 minutes. So before we get into any more, so let me ask you that, because we can talk about you at a later date, even though it is exciting that you're at the University of Pittsburgh. For those of you like me that watch the Pitt. So I know some teams not only have a cardiologist, but they have somebody called a hypertension specialist. What really is the difference there?
Well, a hypertensive specialist is going to focus predominantly on managing your blood pressure, optimizing. Sometimes you're taking different medications that work on your blood pressure in different ways. So you might have a diuretic, which works as a water pill, helps you pee out water. It works very differently than another medication, perhaps such as a direct vasodilator, such as hydralazine. Works very different from another hypertensive medication, such as metoprolol, which works on your beta-2 receptors and has your heart contract a little less strongly. So every single medication it's a different ends to the same means, but they work in different ways, and you want to really optimize. And kind of the example I always give, if you're a diabetic and you have high blood pressure and you have kidney disease, it's almost a disservice to not be on an ACE inhibitor, because those not only do they help control your blood pressure, but they might also help optimize your renal function, help slow down the progression of diabetic renal disease.
Right.
Very, very different. Where if you're someone who has high blood pressure but also has heart failure, then in those cases you might want to consider beta blockers or other guideline directed medical therapy treatments that not only control your blood pressure but also have been shown to have a survival benefit if you have heart failure. So having a hypertensive specialist really sits and kind of looks at the big picture, says, okay, this is your blood pressure goal. This is where you are right now. These are your risk factors. Even more importantly, sometimes these are the other medications you take, because every medication we take may interact with each other. These are the other medications you take. This is what we're gonna prioritize. This is what we're gonna start. This is what we can tweak. This is what we can't touch. So that's kind of what a hypertensive specialist will take care of. But a cardiologist is a specialist of the heart and its major structure. So they'll focus predominantly on that, and also be routinely sending you in for lipid panels, EKGs, echocardiograms, things of that nature.
Now, one last question before I let you go. Some people, there's a debate. Do I just do all of this with my primary care if I don't need surgery, or do I stay followed by my cardiologist? What would be your thought process on that?
Again, this is one of the rare examples where you can't have too many chefs in the kitchen. I don't believe in a less is more approach. I think you need a primary care doctor, because no one is going to understand you and your background and all your medical conditions better than the lady or gentleman that you've been seeing for years and going in with all your medical problems, from the common cold to things that brought you into the ED. So you should always have a primary care doctor involved in your care. However, you should discuss with your primary care doctor and ask, okay, well, what are the specialists I need to see? Who do I need to see? If you go to any cardiologist or any specialist, the first thing they're going to ask you is, who's your primary care doctor? It's always on the first page of the sheet, because it's very, very important to coordinate care. It's essential, because like we just kind of discussed with the hypertensive specialist, you might get prescribed a certain set of medications by one doctor, and they might not directly have the records or have access or know what you're taking for another or what's prescribed by another physician, another provider for another condition. So it's important to have a primary care doctor who kind of keeps tabs on all that, oversees everything, and also just someone that knows you and has that continuity with you to really help guide you. I don't think there's any drawback in managing with your primary care doctor, but if you have a specialist and have them involved in care and have that multidisciplinary team, I think that's really when you get a certain level of care that you can't get with just one provider alone.
It's like getting boutique without paying boutique prices.
Exactly.
Well, and my primary care calls themselves the spine, and all the pages are your specialists. So she's able to be the go-between when we're just at our limit of plain middleman. Let the primary care ask those questions for you.
Even now, like I'm on a pediatric surgery rotation. We always arrange follow-up with the primary care doctor. We always arrange follow-up in the clinic with the surgeons. We always want to make sure that there's that continuity in it. I can't think of why it wouldn't be beneficial to have all your providers on the same page, all working towards the same goal. And it's really that's really the beauty of being here. Everyone offers something different, and I think we could talk about it for hours. Or each, like,
we will. I'm actually going to have you back either at the end of September or October when you're free, whatever, who knows when that happens. And we're going to talk about each of these in greater detail, which we are using your post from last year. And then we're going to talk a little about you, my friend, who started with us as a med student, and look where you are now in your first year's residency. So take care.
An intern is a glorified med student. Don't let
anyone tell you otherwise. Hey, go save those babies.
So
Thanks for joining us. All right, listen. Hey, everybody, don't go anywhere, because what I want to do, which is jumping ahead, I know, but I don't want to leave us hanging on this topic a little bit. So I am pulling up, because I think I've got this scheduled actually. I think I did. If I did not, we're going to go find it real quick. There was a post about the different clinicians that we tend to use within this community, and the differences between thoracic versus cardiac surgeons, or vascular surgeons. I'm just trying to find the title. I know I had it out here, and I'm not finding it right now, but I'm looking for it. So give me just, here it is. I found it. There it is. Yay, I knew I put it right where I wanted it. Okay, so this is going to be zhuzhed up just a little bit. I'll share my screen real quick for you as I unexpectedly decide to read through this. But this is really important because I know, did I get this on the right screen? I did. I know a lot of times we get confused between, let's just start off with just this, and we'll have Adam take us through the rest. But of the surgical team, and we're not talking interventional radiology, we're talking about your surgical staff. You're going to have your cardiothoracic surgeon and your vascular surgeon. Now, the key here is that your cardiovascular surgeon, or just your vascular surgeon, can do surgery anywhere on your aorta, anywhere, top to bottom. However, the cardiothoracic surgeons only do in the chest level, but that also does include the heart, your esophagus, your trachea, your lungs, anything that's in thoracic. So it doesn't necessarily mean that it is just your aorta related, but they can specialize in that. So you can have somebody who specializes in that type of surgery. So let's talk about this a little bit. We're going to just compare for the purposes of this show that I know I don't have Adam here. I'm sorry you're stuck with me and I'm not a doctor, but he wrote this. So while your cardiothoracic and your vascular surgeons tend to work together, depending on the type of case, when it comes to aneurysms and dissections in the aorta, their expertise and their training when it comes to these common surgeries are very unique and can be very different. So let's talk about the CT surgeons or cardiothoracic surgeons. So these ladies or gentlemen, they basically are beloved heart specialists. They are the people that handles the specialization of surgical repair of diseases that involve the heart and the lungs. Okay, so think of the things that are in your chest. Your CT surgeons, they complete medical school before starting their residency program. And just as Adam or Dr. Ahmed, I have to get used to calling him Dr. Ahmed, alluded to, residency from day one is not necessarily right into a cardiothoracic program. He is right now in year one and he is in a pediatric program. And we've talked about his thoughts and feelings about that a little bit. So even though you do rotate in med school a little bit, there is a residency program. It's the first 2 years is some circulation into different specialties before you then have that ability to go into the area that you want. So during residency, the surgeons will learn general surgery procedures and then have time dedicated that gets followed up by cardiothoracic surgeries, which are focused primarily on surgeries of the heart and lungs. But it doesn't start that way, but it'll end that way. So a good rule of thumb is that their main focus of operation actually involves the chest organs and surrounding blood vessels. Okay, common surgeries done by CT surgeons include coronary bypass surgery. We've heard of that, a valve repair, a heart or lung transplant. So we can go as small as, which it's not small, valve repair, to as large as a heart and lung transplant. And of course, they are dealing with aneurysms and dissections of the thoracic area. Okay, now let's move on to the vascular surgeons. So these, ladies and gentlemen, are the vessel specialists, hence the word vascular. And their main focus really is going to be treating diseases that our entire vascular system holds. So that can be arteries or it could be veins throughout the entire body. And this includes vessels that would be primarily near the stomach. It could be also in the limbs, near the limbs. It could be, of course, vessels that have to do with the heart, such as the aorta. So you see here that your cardiothoracic is just the chest, whereas your vascular would be kind of like everywhere, okay? All of those major arteries and vessels. So similar to your cardiothoracic surgeons, your vascular surgeons, they go to medical school, right? And they spend some time learning general surgery, which is your residency program. But then they go on to train in vascular surgery. It's a very broad scope there, but that emphasizes the surgical treatment of vessels throughout the entire body. And the difference here, because vascular surgeons and CT surgeons, the biggest difference is that vascular surgeons can find themselves operating far away from the chest, such as an artery in the neck or it could be blood vessels in the from peripheral trauma, such as a limb injury or carotid artery disease. If you lost a limb and you have a major artery bleeding out, you're going to get your vascular surgeon to take care of that. So it doesn't have to be the aorta. But when it comes to our aortic health, your CT and vascular surgeons, they're the superheroes. Okay, they're the superheroes, and they often team up together to diagnose and treat aortic dissections and aneurysms together as a team. So this means after you have your CT or your echo or your MRI results and they come in and everybody's taking a look, they may review the images together to kind of plan the best way to repair any damage that you might have. And based on what part of the aorta, which zone of your aorta has the disease, one might find themselves actually being operated on by a CT surgeon, or it could be a vascular surgeon, or it possibly could be both. For example, open surgery is usually needed if an aneurysm or a dissection involves the ascending aorta. That's open, okay? And a CT surgeon is really going to be the one that's going to open the chest. And they're going to safely repair the areas of damage, taking great care to ensure the great branches that come off of the aorta to feed the blood to the brain, that they remain intact. Conversely, for a type B, which remember we've heard Dr. Uterman say ascending, so anything that's descending, your type B dissections, which are after your arch, they're going to involve the descending aorta, which is further away from the heart, less immediate blood pressure and blood volume, or those that are traveling down the arteries of the leg into the iliac. That's all going to be vascular surgeons, okay? They're going to be able to really smoothly perform something endovascular. They can deploy these durable grafts to fix any leakages or any aneurysms. So here you've got it. We've talked about this before. Your type A incorporates a type 1 and type 2. So one of these is DeBakey, and the other one, I forget now, I can't, begins with an S. It's escaping me. There's the DeBakey, and then there's the Sanford. The DeBakey, Dr. DeBakey, broke this down into type A or type B dissections. Stanford was actually a 3-level classification. Anything that was type 1, which was primarily in the area of the arch or down, or just the ascending, that was type 1 and type 2. We now know that as type A. Type 3 was strictly after the branches on the arch, which we now know it commonly as a type B. So type 1 was from the root all the way through the arch down in towards your iliacs, okay, it can go that far, or it was just the ascending. That is 1 and 2, or type A, and type 3 or type B is strictly the dissection after the 3 branches that come off the arch. It also, these are the different areas I would guess they would talk about when it comes to aneurysms as well, but this is primarily used, these classifications, for dissection. So if you need surgery, I kind of feel like it's important to understand the different roles of your cardiothoracic surgeon or your vascular surgeon. Like, really understand who they are, what is going on with you, and get a feel for who is going to really be the best to participate in your care. And the important thing to know is that regardless of who you or your loved one sees, these teams, they work to ensure that you're going to get the best care. And they have dedicated a great portion of their lives towards training to be experts in their field. And if you want more information about cardiothoracic surgeons or vascular surgeons and their work, we will have links for you. We're going to have a big post for you in September. Speaking of September, you guys, as I click off of this, speaking of September, let's get off of here so I can share my screen. It's a big month. It's a big month, and it's already happening. Like, the buzz is in the air. So for those of you that are on Facebook, we are turning Facebook into a sea of red right now. We've been creating specialized profile pictures. We've been doing this for quite a few years now. many years. I know other organizations are jumping on the bandwagon, and quite frankly, that's amazing. Whatever you choose to do, whomever you decide to choose to create your profile picture with, that's awesome. The more awareness we can put out there, the better. But we do have these profile pictures, and all you need to do is message me or email me at Karen, Carin, at aortichope.org. And I would love to create a profile picture for you that you can use in social media. In addition, we are in the throes right now of accepting photos for our 7th annual Hope campaign. This started off being called This Is What Hope Looks Like. And I guess that's still the underlying heart feeling, mushy, gushy, emotional process behind this. We want to know what hope looks like. You know, there's a lot of emphasis sometimes on the key individuals who lost their lives to aortic disease. And while that is very important, and it's always important to remember, it's also very important to acknowledge who you have something in common with and what hope actually looks like, right? All of you, myself. So we want your pictures. I would like it non-medically. I really don't like the lit up like a Christmas tree look. So let's get some of those hopeful pictures. I don't care if it's you and your dog. I'd love it if it was you and your physician holding a copy of one of our patient guides. I mean, like, that would be amazing. It can be you and your family. It can be watching your kid graduate. It could be what you're doing over the summer. I don't care. Just something that really resonates with you, makes you feel hopeful. Email that to us at info@aortichope.org, and we will be sure to include you in our video that will be shown on September 19th, which is typically known as Aortic Dissection Awareness Day. It's now also Aortic Disease Awareness Day. Just send it to us by the 14th so we can get these videos together featuring you in this, letting the world know what hope looks like. So the last thing that I can say before I say some hellos to people and run out of fillers, or I'm going to give my whole entire month of September away, is we have, oh my gosh, there's so many exciting things to share with you guys. I'm like bursting at the seams trying to create the greatest post that I can about just a bunch of really exciting stuff happening. So this is an entire month dedicated to educating all of you about what aortic disease is. And it's not even so much anymore for all of you to learn and digest this, which is important. But we know that dissections are rare and aortic disease is much more common than you think, which is why we tell everybody to think aorta and to think family. This is really for your family, for your friends to learn what aortic disease is, because it's often dubbed the silent killer. Aortic aneurysms are typically not symptomatic, and so you could be walking around with one and not know. And this goes beyond high blood pressure. It goes beyond some of the things that you've decided in your brain is what a person with aortic disease look like. I guarantee you, I walk by people and they do not know that I am going to be having open heart surgery myself coming up mid-January. And believe me, we'll be talking a lot about that. I'm in the process right now of doing a project related around that, really solely for myself. No, it's not true. I think that nobody's done something like this before, and it's going to help me process, but also the end goal is to take all of you through the journey, a very realistic journey of the emotions that go down and the questions that are asked and the physician's responses and your family's responses to learning that you're going to have your chest cracked back open. So we're not always privy to that. That's usually very personal, and it goes on between family members behind closed doors. But if you know me, I'm not a closed door person. I'm an open door person, because the more I know, the easier I think it is for me to go through something. So I have to believe there's others like they're out there like me, that the more you know, the more human and real we can make this, the less scary, hopefully, it will be. So I'll be taking you through that journey. But September is all about talking about the aorta. What is the aorta? Like, who talks about an aorta? It's not like it's an elbow or your eye or a head. It's this thing that you can't see, and yet it is the lifeline, the superhighway of your entire body. It's what's bringing oxygenated, rich blood to everything. I can make it sound so exciting, right? September is one of my most exciting months. So we're going to talk about that. We're going to talk about thoracic aneurysms. We're going to go right into abdominal aneurysms. We're going to go right into community resources and what exists out there for everybody. Then we're talking about a little bit about some great collaborations that are taking place. Our reading resources page and what we offer there. The different types of clinicians. We're moving into genetics. We're going to have some really fantastic 12 or 13 different live events talking about all of these topics, believe it or not. We're going to talk about the different medications. Yes, we have a guest speaker for that too. The medical terminologies that you typically hear within the community and what they actually mean. And no, AAA does not mean ascending aortic aneurysm. I mean, you can think it means that, but it actually means abdominal aortic aneurysm. Just saying. We're going to talk about the different types of diagnostic testing that takes place. We're going to then go into what we have to offer as Aortic Hope. Hope Mail, that's a topic. Pre and post-op questions that were created by the community for the community. Then we have a whole exciting week. See, starting September 15th, oh my goodness gracious, not only is it Aortic Disease Awareness Week for some organizations that condense it to a week, it's Heart Valve Disease Awareness Week. Like insane. I think it's even peripheral artery disease. Like there's so much going on in September, oh my Lord. So we're going to talk about heart valve disease in general when it comes to the aortic valve, because we do not delve into heart related diseases at all. Strictly, we chop it off at the aorta, you guys, at the aortic valve. And then we're going to talk about the difference and why we need to speak about women and heart valve disease. There's a lot of subtle and not so subtle differences between how women present with heart valve disease or dissections and men. And it's important to know that. We've all heard that heart attacks present differently, but let's talk about the stuff in our world, right? We're going to talk about the different ways to treat heart valve disease, the different types of heart valves that are out there, what's coming down the horizon, down the pike, very exciting things. Then we're going to talk about the aortic disease, the patient guide, that booklet that you just saw. It is Aortic Hope's #2 patient guide. And then we're going to talk about aortic dissections, everything to do with that, and our first patient guide, aortic dissection, the patient guide. We're going to get into the spoon theory. If you don't know what it is, you're going to have to wait to find out, but it is a really great way to visually explain to loved ones, friends, family, about how you can look so good but be so exhausted from something that they don't see and can't understand. Caregivers, you're going to get a lot of time and attention because you deserve it. You are kind of one of our backbones as well, because in this world we have more than one. Caregivers, very important. We're going to highlight you. We're going to talk about support groups. We're going to talk about care packages that we offer, Help Techs, which is an organization we work with for some emotional support. Obviously, Think Aorta, we're going to go right into a Think Aorta Day as well, and why it's so important to be preactive and preemptive and talk about your aorta and know your family history. Then we're going to give you guys a lot of relaxation techniques. We're really excited about talking about that. Grounding techniques. We're going to talk about Rare Patient Voice, who is actually down the street from us here in Maryland, who we've been partnered with for many, many years. And we're going to talk about why it's important for you to join that organization. Trauma, PTSD, emotional issues that come up with aortic disease, we're going to talk about. And we're going to also highlight a lot about our YouTube events and what you find here on this YouTube channel, which has become essential to Aortic Hope. And that is pretty much going to be our month, sprinkled in with, again, oh gosh, let me see if I can line them up. We've got Dr. Udelman, fan favorite, Dr. Kristen Watson talking about medications, Dr. Kyle U. Daly from University of Alabama. We have Dr. Stacy Fisher talking about cardiology and blood pressure. Dr. John Martin coming on again this year to talk about abdominal aortic aneurysms. Amy Wagner talking about emotional trauma and PTSD. I am missing somebody. Oh, we're talking with Robin Peacock, and she has 2 guests from Heart Valve Voice. We are talking with Tara Cohen from Lawrence Hope. Okay, it's coming to me. It's coming to me. We just talked with Adham briefly. We'll get him back in. And blah, 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 blah. I'm missing 1 or 2 because it's only 10. But there's whoever I'm missing, it's because they're so special. Oh, Dr. Caterino, he's coming, but we had to push him into October because I filled up. So because there's a Jewish holiday in there, there's a lot going in. There's an Ask a Doctor. There's a grief support group this month. We've got a live event with a community member, Dee Riete. She's going to be finally meeting with us and taking us through her aromatherapy that she's licensed. And we're just going to learn the basics, just learning the basics, not getting into any blending or any of the arts and crafts. She's going to be another one of our aortic artists. So yes, in the last 2 weeks, I have been down in the complete, utter bottom barrel dumps in pain from my shoulder, only to get the news that I had to have my chest crack back open. So this is called Disassociating 101. And this is what it looks like. But I'm gonna have no choice but to associate with it and figure it out and work through it and process. And this is all going to be so exciting and so fun. So on top of everything I just said to you, we're giving away 20 or 30 bracelets every Wednesday. Instead of once a month, we're giving away something to multiple people. So you want to participate on Wednesdays. Please, please, please do. And if at any time you're so thoroughly enjoying what we're presenting to you, please don't be shy. Please donate, because 100% of the monies that we raise go towards being able to do all of this for all of you. None of us are compensated, but it does take money. So we appreciate every time anybody decides to start a Facebook fundraiser for us. One of the other things that's very exciting is that I know that you are aware we have Aortic Hope Canada, but we are now going to have Aortic Hope Canada in French, because I know there are a lot of people in Canada that only speak French. They do not really speak English. That is not their primary language. And so we are going to be talking about that when we get into this month, about what that's going to look like. We're so super excited. And I think that's it for me giving you the teasers about what begins, I guess, basically in tomorrow. Yeah, it's Sunday. Oh my God, September's here. I can't believe it. All right. So sorry that was so shut down and quick and what have you, but this is the life of a physician. And, I wish him the best in whatever situation he's walking into, because we now know that it is pediatrics, so it does involve a child. And I want to just say hi to whoever's out there. Who's with us, Josh? What's going on out there?
Tom says hello all. He says it's exciting month. Looking forward to the bridge walk and meeting his friends. And Susan Comer says excellent lineup for AHTV speakers. Thank you.
Thank you. Yeah, that's the other thing that's happening. We have the bridge walk taking place across the Brooklyn Bridge on September 27th at 11 a.m. We're all meeting in Camden Plaza. That information will go up. That is free. That's free for anybody who can come out. There will be another event in October at Stony Brook, which I believe is up in Long Island, New York. It is open to patients. I'm getting all the details. It was a little sketchy, but I got them in late last night. So I will be posting them for anyone that might want to attend. But hey, thanks, Susan, and thanks, Tom. Yeah, we're pretty excited about September as well. And I hope you got enough out of that from Adam to understand the general nature of the different types of doctors, the clinicians that are just placing hands on you versus the ones that might be cutting into you. And we will talk about that some more in the month of September. So right now, that is it. I will say adios. Au revoir. That's what it should be saying, because that's coming soon. And thank you again so much, you guys. I will be back on Tuesday for our weekend review at 3 p.m. since tomorrow is our Labor Day. So everybody enjoy your holiday. Thanks so much. Don't forget to click like, subscribe, and share. Have a good night.